Welcome to the deep dive. We're here to cut through the noise and get right to the essentials. Today, we're tackling something really fundamental for all you nursing students: pediatric gastrointestinal dysfunctions. We know it can seem overwhelming, a lot of ground to cover, so our mission today is simple: give you a clear, focused roadmap. We'll look at key conditions, what's going on inside, what signs you'll see, and crucially, your role in caring for these kids.
Exactly. This is about equipping you with that core knowledge, understanding why a newborn might struggle with feeding because of something they're born with, or uh, picking up on those signs of inflammation in an older child's gut. We'll break down the pathophysiology, the why behind it, all the signs and symptoms you need to spot, and of course, the essential nursing interventions and treatments.
Okay, that sounds like a great plan. Pediatric GI is such a broad area, though. Where do we even start to get our bearings?
Good question. Let's lay down a basic framework. Generally, these disorders fall into a few buckets. You've got congenital anomalies issues present right at birth. Then there are inflammatory conditions, malabsorption disorders where nutrient uptake is the problem, and motility disorders, problems with how things move through the system.
Okay, that helps categorize things. So when a child first comes in and you suspect a GI problem, what are those first clues, the common symptoms that kind of wave a flag?
Well, the most frequent things you'll encounter are vomiting, diarrhea, and importantly, is it sudden or ongoing? Also, abdominal pain, failure to thrive, not growing or gaining weight as expected, and constipation. These are often the first signals.
Right, those broad indicators. So say a child presents with persistent vomiting. How do you start figuring out what's causing it? What's the assessment process look like for you?
It always starts with good detective work, a really thorough history. You ask about everything: diet, growth charts, bowel and bladder habits, any family history of GI issues.
Makes sense.
Then the physical exam. You look closely at the abdomen inspection. Listen for bowel sounds, auscultation, and gently feel the abdomen palpation, checking for tenderness, any masses or swelling. And then, to really see what's going on, we bring in the diagnostic tools.
Okay, what kind of tools are we talking about? Stool samples, imaging?
Yeah, all of the above,
Yeah.
potentially. We might start simple, like stool tests for occult blood, hidden blood, or cultures to check for infection. Imaging is huge. Abdominal x-rays, ultrasound, maybe even CT or MRI if we need a more detailed look. Endoscopy, using a scope to look inside the upper GI tract or the colon, gives us a direct view. And blood work, of course. CBC, electrolytes, liver enzymes, they all add pieces to the puzzle.
Got it. That paints a clear picture of the initial workup. Now let's focus on one of those common symptoms you mentioned: vomiting. What are some typical causes in kids, and what are nurses immediately worried about?
Oh, vomiting can be caused by so many things. A simple virus, maybe an obstruction somewhere in the gut, or even sometimes issues related to the brain or central nervous system. Our biggest immediate concerns: dehydration, definitely, losing all that fluid, and also metabolic alkalosis, because they're losing stomach acid.
Right.
So nursing care focuses on finding that cause, maybe giving antiemetics to control the vomiting, and critically managing fluids and electrolytes.
Okay. And the other really common one, diarrhea. We see that all the time, especially with the little ones.
Oh, absolutely. We usually differentiate between acute diarrhea that's sudden onset, often viral, like rotavirus,
Yeah.
and chronic diarrhea, which lasts, say, longer than 2 weeks.
And the big risk there is
Dehydration again,
big time.
especially in babies. And with diarrhea, you can also see metabolic acidosis from losing bicarbonate. The absolute go-to treatment is oral rehydration therapy, ORT, using those specific glucose electrolyte solutions like Pedialyte.
Right.
And importantly, keep feeding them, especially breastfeeding. Keep the nutrition going.
What's a key point?
And another really key nursing point: generally avoid antidiarrheal meds in kids. That's important to remember.
Definitely noted. So you've stressed fluid and electrolyte management for both vomiting and diarrhea.
Yeah.
Can we dig into that a bit more? How do we approach it, especially if a child is seriously dehydrated?
Sure. For mild or moderate dehydration, those oral rehydration solutions usually do the trick. We teach parents small sips, frequently.
Okay.
But if it's severe dehydration, we need IV fluids, and quickly. Usually we start with a bolus, a fast push of something like normal saline or lactated ringers, just to get that circulating volume back up fast.
And then?
Then we switch to maintenance IV fluids, often with some dextrose for energy. And throughout all this, nursing vigilance is key. You're tracking weight daily, measuring every bit of intake and output, watching those serum electrolytes like a hawk, making sure we're correcting things effectively.
Constant monitoring. Makes perfect sense. Okay, let's shift gears and talk about some specific disorders. Maybe start with the ones kids are born with, the developmental ones.
Good idea. A common one you'll see is cleft lip and or palate. This happens really early in pregnancy. The tissues just don't fuse completely.
And that causes immediate problems, I imagine.
Yes, feeding is the big one right away.
Yeah.
They can't create good suction.
Which increases the risk of aspiration.
Exactly. Milk going into the airway. They're also more prone to ear infections, otitis media, and can have speech issues later on.
So nursing care initially is focused on feeding support.
Absolutely. Using special nipples, special bottles, keeping the baby upright during feeds, burping frequently to minimize that aspiration risk. The fix is surgery. Lip repair usually around 2-3 months. Palate around 6-12 months.
Okay, important timing there. Another congenital one you mentioned earlier was esophageal atresia and tracheoesophageal fistula TEF. What exactly is going wrong there?
So with esophageal atresia, the esophagus just doesn't connect properly to the stomach. It often ends in a blind pouch. And frequently there's also a TEF, that fistula, an abnormal connection between the esophagus and the trachea, the windpipe.
So food or saliva can go straight into the lungs.
Precisely. Which is why the signs are so alarming.
What are those signs? What would make you suspect TEF in a newborn?
The big 3 C's. Coughing, choking, and cyanosis, especially when they try to feed. Plus, lots of drooling, because the saliva has nowhere to go.
And immediate nursing actions.
NPO, nothing by mouth, immediately. Constant suctioning of the mouth and airway. This is a surgical emergency. They need repair. And post-op, you're watching their breathing incredibly closely. High risk for aspiration, respiratory distress.
Wow, yeah. These congenital conditions really highlight the need for sharp assessment skills right from birth. Okay, let's move to motility disorders. Hypertrophic pyloric stenosis. What's the issue there?
Right, pyloric stenosis. It's all about the pylorus, that muscle acting like a valve at the stomach exit. It gets hypertrophied, meaning thickened.
Thickened so much it blocks the opening.
Exactly. It narrows the outlet, so food struggles to get from the stomach into the small intestine. A gastric outlet obstruction.
And how does that show up? What classic signs would a nurse see?
The absolute hallmark is projectile vomiting. Forceful, often right after feeding. You might also see visible peristalsis waves moving across the baby's upper abdomen as the stomach tries hard to empty.
Can you feel anything?
Sometimes, yes. An experienced examiner might palpate what feels like a little olive in the uppy right abdomen. That's the thickened muscle.
And diagnosis, treatment.
Usually confirmed with an ultrasound. And the treatment is surgery, a pyloromyotomy. They just cut the thickened muscle to open things up. Pre-op, managing dehydration is key for nurses.
Okay, clear enough. Then there's Hirschsprung disease. What's the underlying problem in Hirschsprung's?
Hirschsprung's is about missing nerve cells, ganglion cells, in a segment of the colon. These cells are crucial for peristalsis, the muscle contractions that move stool along. Without them, that part of the bowel just doesn't work properly. It can't push stool forward.
Leading to a blockage, functionally speaking?
Right. A functional obstruction.
And how does that present? What clues point towards Hirschsprung's?
In a newborn, the big red flag is often failure to pass meconium, that first stool, within the first 24-48 hours. In older infants or kids, it's usually chronic, stubborn constipation. You might hear about ribbon-like stools. Abdominal distension is common too.
Diagnosis.
Definitive diagnosis comes from a rectal biopsy, looking for those missing ganglion cells under the microscope.
And treatment is surgery again?
Yes, surgical resection of the affected bowel segment. Sometimes they need a temporary colostomy while things heal.
Okay, motility issues covered. Let's switch to malabsorption. Celiac disease, lots of people know the name, but what's actually happening immunologically?
Right, celiac is an autoimmune condition. It's triggered by gluten, the protein in wheat, barley, rye. In someone with celiac, gluten causes an immune attack on the small intestine lining. Specifically, it damages the villi.
Those little finger-like things that absorb nutrients.
Exactly. So when they get damaged, nutrient absorption goes way down, malabsorption.
And the symptoms reflect that lack of absorption.
They do. You often see stenoria, those fatty, foul-smelling stools. Failure to thrive because they're not getting nutrients. Abdominal bloating, maybe irritability or fatigue.
And the treatment is purely dietary.
It is. A strict, lifelong, gluten-free diet. No wheat, barley, or rye. Ever. Patient and family education on that diet is a huge nursing role.
Huge. Okay. What about lactose intolerance? How is that different? It's not autoimmune, right?
Correct. Totally different mechanism. Lactose intolerance is an enzyme deficiency, specifically lactase. Lactase is needed to break down lactose, the sugar, in milk. If you don't have enough lactase, The lactose doesn't get digested in the small intestine
So it travels further down.
to the large intestine, where bacteria ferment it.
Ah, causing the symptoms.
Right. That fermentation produces gas, leading to bloating, cramps.
Hmm.
It also draws water into the colon, causing diarrhea. Symptoms hit after having dairy.
And management.
Avoid lactose, so lactose-free diet or limiting dairy. Or you can use over-the-counter lactase enzyme replacements before eating dairy.
Okay, clear distinction there. Now, onto inflammatory conditions. Appendicitis. Every nurse needs to know about this one. What are the absolute must-knows?
Appendicitis inflammation of the appendix is super common, and it's a surgical emergency. Can't miss it. Classic presentation is often pain starting around the umbilicus, then migrating to the right lower quadrant McBurney's point.
Usually with fever, vomiting.
Yes, often fever, vomiting, and guarding, where they tense up their abdominal muscles when you touch the area.
And the big danger is rupture.
That's the major concern.
Mm-hmm.
Rupture leads to peritonitis, widespread infection in the abdomen. Life-threatening.
Treatment.
Appendectomy, surgical removal. If it's ruptured, they'll need strong antibiotics too. Nursing involves pre-op prep, pain control, post-op monitoring for infection.
Got it. Rapid response needed. What about Meckel diverticulum? What is that?
Meckel's is a bit different. It's a remnant from fetal development, a little pouch in the small intestine wall. Most people have one and never know it.
But sometimes it causes problems.
Sometimes, yeah. The main complications are bleeding or obstruction.
Bleeding? How does that show up?
Typically as painless rectal bleeding. It can sometimes be quite a bit, leading to anemia. Diagnosis might involve a special scan, a Meckel scan. Treatment for symptomatic ones is surgery to remove the pouch.
Okay. And then inflammatory bowel disease, IBD. You mentioned Crohn's and ulcerative colitis. Can you briefly contrast those?
Sure. Both are chronic inflammation, but location and pattern differ. Crohn's can be anywhere from mouth to anus. Patchy inflammation affects all bowel layers, higher risk of fistulas.
Okay, patchy, anywhere. Ulcerative colitis.
UC is typically just the colon, usually starts in the rectum and moves up continuously, and it generally only affects the inner lining.
But they share symptoms like pain, diarrhea, growth issues in kids.
Yes, abdominal pain, diarrhea, sometimes bloody, and definitely growth failure are common to both in children. Treatment involves anti-inflammatories, immunosuppressants, nutritional support, maybe surgery, especially for stubborn UC.
Okay, helpful comparison. Let's talk obstructions and emergencies. Intussusception, what's happening physically there?
Intussusception is like a telescope collapsing. One part of the intestine slides into the part next to it.
And that causes a blockage, cuts off blood supply.
Both. It obstructs the bowel, and it can compress the blood vessels in the bowel wall, leading to ischemia.
What are the classic signs you'd look for?
The classic triad. Sudden, severe, colicky abdominal pain. Kids often draw their knees up. Then current jelly stools that mix of blood and mucus. And sometimes you can feel a sausage-shaped mass in the abdomen.
How's it treated?
Often they try an air or contrast enema first. It can sometimes push the bowel back into place, diagnostic and therapeutic. If that doesn't work, then surgery is needed.
Current jelly stools, memorable image, another emergency. Malrotation and volvulus. What's the critical issue?
Malrotation is abnormal positioning of the intestines from fetal development. This can leave them prone to twisting, that's the volvulus. When the bowel twists on its blood supply, the mesentery, it cuts off circulation. Leads to ischemia, necrosis, dead bowel. Very serious.
And the red flags for volvulus. What screams emergency?
Bilious vomiting. Green or yellow vomit, that's a warning sign. Plus abdominal distension requires immediate surgery. No delay.
Definitely an emergency. Shifting to liver and bile ducts, biliary atresia.
Biliary atresia is blockage or absence of the bile ducts that drain bile from the liver. Bile backs up, damages the liver, leads to cirrhosis.
And in an infant, what points to this?
Key signs are jaundice that last beyond the first couple of weeks, dark urine, and pale, clay-colored stools, because bile isn't reaching the intestine.
Treatment.
Early diagnosis is vital. They often do the Kasai procedure first, trying to create drainage, but many ultimately need a liver transplant.
Very serious.
Yeah.
It's okay. And hepatitis, inflammation of the liver. What causes that in kids?
Several things. Viral infections are common. Hepatitis A, B, C can also be drug-induced or autoimmune, where the body attacks its own liver.
And symptoms are pretty general liver symptoms.
Often, yes. Fatigue, jaundice, poor appetite, nausea, maybe some upper right abdominal pain. Management is usually supportive rest, nutrition, hydration, and importantly, we have vaccines for Hep A and B. Prevention is key.
Good point on prevention. Okay, nearly there. Let's cover some very common issues. Constipation and encopresis. Constipation in toddlers happens all the time, right?
Oh, very common. Often related to diet, not enough fiber or fluids, and also toilet training dynamics.
And management is usually about.
Education for parents. More fiber, more fluids, regular toilet routines, positive reinforcement. Sometimes stool softeners might be recommended by the doctor.
And encopresis, how does that relate?
Encopresis is involuntary stool leakage in a child who should be toilet trained, usually over age 4.
Mm.
Almost always, it's due to chronic constipation and fecal impaction. The rectum gets stretched, they lose the sensation to go, and liquid stool leaks around the hard mass.
Sounds distressing for everyone.
It really is. Treatment needs a multi-pronged approach. First, a bowel cleanout, then retraining bowel habits.
Yeah.
And crucial psychosocial support for the child and family. It carries a lot of stigma.
Absolutely. Lastly, short bowel syndrome,
Yeah.
SBS. What defines that?
SBS happens after a large part of the small intestine is surgically removed, maybe due to something like NEC and preemies or volvulus. There's just not enough bowel left to absorb nutrients properly. Leads to malabsorption, chronic diarrhea, nutrient deficiencies.
Management sounds incredibly complex.
It is. Requires a whole team. Often starts with TPN IV nutrition, then very gradual introduction of enteral feeds, usually via tube. It's a long road of adapting feeds, managing deficiencies, sometimes using meds to slow transit time. Long-term nutritional support is essential.
What an incredible range of conditions we've covered. Thinking about our listeners, the nursing students, what are the absolute core nursing considerations that cut across all these different GI disorders? What should they really keep front and center?
Great question. The nurse's role is just central, actually pivotal. First, meticulous monitoring. Hydration status, nutritional intake, growth patterns. You're the eyes and ears, often spotting subtle changes first.
Being that constant observer.
Exactly. Second, emotional support for the child and the family. These conditions, especially chronic ones, are incredibly stressful. Compassion goes a long way.
Definitely.
Third, education. This is huge. Teaching families about diets, medications, post-op care, and critically, teaching them what warning signs to look for at home. Empowering them.
Right, making them partners in care.
Absolutely. And finally, coordinating care.
Yeah.
You're often the hub, working with doctors, surgeons, dietitians, social workers, ensuring that holistic approach, making sure all the pieces fit together for the child's benefit.
That really paints a picture of the nurse as a vital integrator and advocate. So wrapping up this deep dive, we've covered a ton, from congenital anomalies to inflammatory issues, motility problems, always focusing on the why, the what to look for, and the nursing what to do. It's clear that having this solid foundation in pediatric GI is just non-negotiable for providing safe and effective care.
It truly is. And for all of you listening, remember, this is your starting point. Keep building on it. Dive deeper into conditions you encounter. And really work on honing those assessment skills. Learning to trust your gut, pardon the pun, when you notice those subtle signs can make all the difference.
Well said. And on that note, here's something to mull over. Given how varied and sometimes subtle these GI presentations can be in children, what specific active strategies can you, as a developing nurse, use daily in your practice to sharpen your assessment skills and build that intuition need for early recognition, especially when things aren't textbook perfect? That ability to see the patterns, to connect the dots early, that's where exceptional nursing really shines. Thanks for joining us on the Deep Dive.